Welcome everyone. This video is on Serous Otitis Media and it is made for the benefit of third year MBBS students who are preparing for the theory exam, NEET PG and next examination. So what is serous otitis media? Serous otitis media is a collection of fluid in the middle ear. It is a it is a collection of non-purulent fluid. Okay, so this fluid can be thick and viscid or it can be thin and serous, and it is an insidious condition, and the fluid is almost sterile and it is mostly seen in school going children. Now moving on, pathogenesis and etiology. So serous otitis media, its pathogenesis includes two main mechanisms. One is malfunctioning of the eustachian tube and the other is increased secretory activity of the middle ear mucosa. So, as we all know, the eustachian tube is responsible for draining any kind of fluid in the middle ear, and also it is responsible for maintaining pressure balance. So, when it fails, that fluid is getting it's not being drained, so obviously it will get collected in the middle ear. On top of that, the middle ear mucosa will start secreting, its secretory activity will increase. So these two mechanisms will lead to the accumulation of fluid in the middle ear, leading to serous otitis media. Now, etiology. What causes this malfunctioning of eustachian tube and this increased secretory activity of middle ear mucosa? So, malfunctioning of eustachian tube can occur due to various reasons, which we saw in acute suppurative otitis media also. These include adenoid hyperplasia, chronic rhinitis, sinusitis, chronic tonsillitis, tumors of nasopharynx, palatal defect. All of this can cause malfunctioning of eustachian tube, in the sense that it gets blocked and the drainage will not happen. That is the main defect over here. Then allergy. In allergy, what will happen? This allergy can be chronic or it can be seasonal. In allergy also there will be edema and hyperemia of the eustachian tube, the nasopharyngeal end of the eustachian tube, and when this happens again it gets blocked. Then in unresolved otitis media, sometimes the otitis media will not be resolved. With antibiotics the infection will get inactivated but it won't be completely resolved. So in such conditions also it can lead to serous otitis media. Then recurrent viral infections with adeno or rhinovirus, all of this can cause serous otitis media. Also, allergy conditions can increase the secretory activity of middle ear mucosa. Now, moving on, clinical features. So, it is mostly seen in children of 5 to 6 years of age, and they will come to you with hearing loss, delayed and defective speech. Why delayed and defective speech? So when they are they are not able to hear properly, so they will not be able to listen to people talk, right? So their speech development also, it might be delayed and it might be defective, and they might have mild ear pain. Now, signs on otoscopic investigation, what you will see is that the tympanic membrane, it will appear dull and opaque. It won't be that lustrous like how you usually see a tympanic membrane. It will look dull, and then there will be loss of light reflex, and it might appear yellowish, grayish, or even bluish. Okay, what a bluish is like, it's not that common. It can appear yellow and gray, but then you should remember bluish also. Serous otitis otitis media can appear, the tympanic membrane can appear bluish also. Now, typically in acute otitis media, we saw cartwheel appearance of this tympanic membrane. But over here, what you will see that there will be a thin leash of blood vessels along the handle of malleus and along the periphery, like in this image. There is a leash of blood vessels in the along the handle of malleus and then in the periphery. In acute otitis media, it was the cartwheel appearance all over the tympanic membrane, like that radial, like spokes. Okay, over here, then on otoscopy you will see all these things. Then when you do hearing tests, tuning fork tests, you will find conductive hearing loss, and on audiometry also you will see conductive hearing loss of 20 to 40 decibels. And in impedance audiometry under tympanometry, on the tympanogram you will get a flat curve. What was that flat? It was a B curve which was flat, right? And why it is coming like that? Because the fluid is there, no? So when you do tympanometry, and the that device, it sends sound, and all the sound will get reflected just like that, and there will be reduced compliance of the tympanic membrane also, because it's not able to move because of all the fluid that is collected. So that is why you will get a flat curve, because all of the sound is getting reflected, and there is reduced compliance of the tympanic membrane. This indicates presence of fluid, which is that is the finding in serous otitis media, right? Then next what you will see there is that when you do x-ray of the mastoid, there will be clouding of air cells. Why? Because of the fluid. Some of the fluid will get into the mastoid air cells and they will look cloudy under the x-ray. Next is treatment. So treatment, there are two modalities. The main aim of both of them is to drain the fluid and to get rid of the hearing loss and the pain and all that, and also to prevent the recurrence. So you can do medical and then surgical. Medically, what you can do is that you can give decongestants like oxymetazoline and xylometazoline, just like in otitis media, acute otitis media. And then you can give anti-allergic measures. You can give antihistamines, or you can give, sometimes you can also give steroids if it's like too much. And you can give antibiotics if there is unresolved otitis media, then you can give antibiotics. Okay, then the patient should be advised to keep the middle ear aerated, and the patient is advised to do Valsalva manures. The patient is taught to do it and is instructed to do it. Okay, and when the patient does Valsalva manure, the fluid will be there in the middle ear already, and you can see appearance of bubbles. Okay, through the tympanic membrane you will be able to see, like in this image. Then surgically, what you can do is that you can do myringotomy and aspirate the fluid. What is myringotomy? Myringotomy is nothing but you are just giving an incision on the tympanic membrane, and once you give an incision on the tympanic membrane, the fluid will come out, right? And sometimes the fluid will be thick. Okay, and this by the way, this you are doing only if it is like thick. Okay, if the the mucus is thick, only you are doing it. So first you have to liquefy the mucus. How are you going to liquefy the mucus? You can give saline, or you can give mucolytic agent like chymotrypsin solution, and then the mucus will get liquefied, and then you can give incision on the tympanic membrane and then aspirate it. Over here you can give two incisions, one in the anterior inferior quadrant and one in the anterior superior quadrant. Now why we are giving two incisions? See, anterior inferior you will give one, and in anterior superior you will give one more, because when you anterior inferior quadrant, when you give incision first, some of the fluid will come out, but if you give another one more incision in the anterior superior quadrant, what will happen is that some air will enter through that and it will go and press on the fluid inside, and it will force more fluid to come out through the anterior inferior quadrant. This is known as the beer can principle. So this can be applied over here. Then another way what you can do is grommet insertion. Now this is like if the fluid is too much and it's not coming out all at once, then you can give a small device like this in this image, the leftmost first image, that is a grommet. If you insert a grommet, the fluid will continuously come out through it, and this is placed in the anterior inferior quadrant. Why? Anterior inferior quadrant will not heal easily, right? So that is why we can keep there, so it will stay there for a long time. If it starts to heal quickly, means the grommet will come out, like it will slip out, and all the fluid may not get drained. So if you put the incision on the anterior inferior quadrant, it will take time to heal, and the grommet can stay over there and a lot of fluid can come out. So that's why you're giving incision over there. Then you can do surgical treatment of the causative factor. That is like if the patient is having adenoiditis or tonsillitis, then you can do adenoidectomy or tonsillectomy. That will help to facilitate the recovery. Then you can also wash out the maxillary antra, because it will be having that fluid, right? So you can just remove it also, and all of this can be done along with myringotomy. Now that is all about serous otitis media. Thank you.